When do we finish? 10? Unless I finish early?
Unless you finish early or unless you finish late.
Do you guys mostly finish when? Like
It
10?
depends on the
Or
10, a little after 10 sometimes.
Anywhere between 8 and 12.
Yeah, pretty much.
what's the latest anybody's gone?
Probably midnight.
Yeah.
Really?
I've been here
It's not a
until midnight.
compensation.
Who was that? No, I'm just...
Cardiology is scheduled until 11.
Wow.
So when it runs over, they're 11.
Who does cardiology?
Kelly Coleman.
It's past her bedtime.
Wow.
So she never gets out.
No, yeah, she doesn't usually
Stop.
go early.
Like
All right. All right. I think this is the... Is this the 3/4 or is there one more break? I think there's one more
There
break.
might be another break.
All right. Common communicable diseases of childhood. So...
Man, it's like
There are
200
certain
slides.
illnesses that-
I was trying to break it up.
No, it's good. I like it this way. I feel like we had less breaks last time, and it gets
It gets a
feels,
lot. Yeah, it's
feels
like,
more painful.
another one. Hold on.
yeah.
More
So
rings? Okay.
there are a lot of potentially preventable illnesses. We're living proof now. Measles in the United States that can be prevented with vaccinations that are safe. This is all sick kids should have their blood glucose checked. I don't know. I think if kids are lethargic, then they're falling under your altered mentis status, like sort of in that sense, it should get checked. Really young kids that have been working for a long time with their illness, like a respiratory disease, they can get hypoglycemic. So when you're talking about kids under a year with an acute illness or kids under 6 months, then it's especially if they look fatigued or lethargic, then it's a definite. But most of the time, I don't really check glucose unless like the person's pretty sick. So bronchiolitis. Bronchiolitis is a super common infection. Every one of you probably had it at some point in your childhood, and it's really an infection of the bronchioles, lungs and airways, and it's mostly, it's almost always viral in nature. Antibiotics don't help, and what happens is they get a droplet infection for whatever it is, and then they start secreting, they have a lot of mucus and excess respiratory secretions, and those secretions just plug up the works, so to speak, and cause sort of an obstructive process. And that's the respiratory failure and the retractions that happen commonly with bronchiolitis. Classic presentation is a typical viral illness. They have a runny nose, a low-grade temperature, and then they start with respiratory symptoms, increased cough, and then that progresses to tachypnea or tachycardic. They have trouble feeding as a result, and that's where your glucose problems occur, because kids don't really have the kind of reserves that I have, and all of us have. And so they deplete their glycogen stores in their liver, and then they get hypoglycemic. So,
Mass murders are back there.
most cases of bronchiolitis really just require nothing. They just get better over a period of 5 days to a week and don't require much. If there's excessive secretions or they're really young, what happens is kids under a year, the bronchioles are really, really narrow. And as a result, it's pretty easy for them to get clogged up. Once kids are over a year, their airways start increasing in diameter. And so a 2-year-old with RSV has far less chance of decompensating than a 6-month-old with RSV or a newborn with RSV. And so patients that are progressing, they could be hypoxic and need respiratory support. They can need ventilatory support if they're not ventilating well because they're so tired from breathing so hard. They oftentimes are dehydrated and benefit from fluids. In severe cases, they require ventilators. I don't know, did we talk about RSV later?
I think so.
Yeah, most cases of bronchiolitis that we see are RSV in winter. And RSV tends to be a 5-day illness. So it's actually pretty important when you're assessing patients with RSV or bronchiolitis to figure out where they are in the context, because if somebody's on day 5 or day 6 and they're mildly sick, you don't worry about them, right? Because they're going to get better in the next 2 days. If they're on day 2 of the illness and they're working to breathe, or day 3, then they've got 3 more days. The day 3 and 4 are the worst. And so if they're not doing great at day 2 or 3, I worry much more about them than if they're at day 5. and still with, some disease. Croup. So, what age group gets croup?
Children.
How old? It's like 6 months to 6 years. So like that, it's a pretty big range. It's funny because after 6, you don't see it that commonly, but every once in a while you see a case of, a 7-year-old with croup. Not common. What happens is croup, another viral caused disease process, and different viruses can cause croup. What's the most common virus that causes croup? Anybody? Haemophilus is the one that the classic croup causing illness. We have these viral multiplex tests now, which cost an exceedingly large amount, and they're not indicated for most of the people that we use them on. But they tell you exactly what the virus is, which is nice because then it's useful information in some cases. It's really designed to prevent, like if you have a 4-week-old with a fever, you have to worry about meningitis and bacteremia as a potential cause because their immune systems aren't great. But if you do this test and you can say that, they have Haemophilus, or they have a rhinovirus, then you don't worry as much, so to speak. And that, coupled with a few other tests, can kind of prove that they don't have bacterial infection, and then you don't have to do a spinal tap on them. So there's like benefit of that test. But it costs a couple $1,000s, and these days it's like Caramount uses it all the time, so now the expectation is everybody else has to use it all the time, and so the parents want it. It's tough. So anyway, croup, most commonly caused by Haemophilus, but we've seen plenty of COVID-induced croup, not uncommonly. And so other viruses can cause croup as well. And what happens is it just looks like a common cold. Little Johnny had a common cold, cough, runny nose, little low-grade temperature, and then at night they develop respiratory distress. They get more inflammation in around their vocal cords, and their airways become inflamed, and as a result, they end up having respiratory distress. And the respiratory distress from croup can be very mild to very severe. Kids every once in a blue moon get intubated from croup. It's not common, but certainly can happen, and I've seen it. But the most cases of croup are pretty mild and go away with you treat it with a steroid, and that's been shown in studies like a dose of Decadron to prevent the need to come back to the ER the next night or thereafter in the illness. And so it tends to be very responsive when you treat it. One of the things about croup, though, that's difficult, and I guess this is true of just respiratory distress in pediatric patients in general, is panic. Panic is contagious, and kids know when adults are panicking. They get panicked. And so what happens is there's a sort of cycle of badness that happens with croup every once in a while, in which the parents are flipping out because the child is having respiratory distress. The EMS provider gets there and is not comfortable with peds, and they start flipping out, and then the kid's feeding in on this and starts working to breathe more. As a result, they're working to breathe more. Their respiratory, their airways become more inflamed because now they're breathing even harder. They get drier. They get more respiratory distress, and it's like a cycle of badness, right? And so, always stay calm. Pretend to be calm, even if you're not internally calm because you have a kid that's seemingly on the brink of respiratory failure. But stay calm because it will have a better outcome on the kid. I've seen it. It's true. I recommend it. It's probably general. Stay calm always. Panic rarely benefits anything unless you're like trying to jump out of a plane, that's blowing up or something. Did you hear that guy, the one survivor from the Air India crash, jumped out of the plane? So, I guess there is some role. So, croup, 3 to 7 days, but the classic is that barking cough that you hear. Once you hear it, you remember it, and then if you haven't heard it, Google it. And then the kids can get your typical sort of airway obstructive process respiratory distress. It's classic. What's the great imitator that you worry about? Like every once in a while, and when I say once in a while, like probably once in a career, but they always teach you patient sounds like croup, but is really a foreign body. Like they inhale a bead or something, and it's teetering on their airway, causing things. I don't mean to make you think that every patient that you have with croup, you're going to be like, is it a foreign body? I realized, I can't remember what I told my daughter the other day, and now, so my daughter has to get a shot every night, and I'm teaching her how to give the shot, but it's an insulin syringe, and so she's taking like a tiny injection, and I'm always like, you have to just make sure you do it perpendicular. You don't want the needle to break off, because every once in a while, and I meant to say, but I didn't want to tell her, IV drug abusers fall asleep and the needle breaks off, and that's how they get a needle in their arm. But I was like, if you do it wrong and you have a bent needle, because when you put the syringe into the vial of insulin, it's easy to bend it because it's such a flexible needle. And then if you inject it and it's bent, it's theoretically you could break it. And so that's what I was trying to say. But now every time she gets her shot, she's like, whew, I made it. It didn't break. She's like, can I see the needle? Can I see the needle? And I was like, it's IV drug abuser or something. But I feel like bad talking about IV drug abusers to a 10-year-old. She probably knows more about IV drug abusers than me with their phone, so who knows. Anyway, so croup. Moving along. So how do we treat croup?
Humidified oxygen.
Humidified oxygen, 90%, a dose of Decadron. And we give the IV formulation, we just mix it with juice and give it orally. It works just as well. And then you don't have to give the kid a shot. And it doesn't make it work much quicker when you give it IM. So in general, you're trying to keep the kid calm, give them juice with Decadron instead of, giving IM. For severe croup, what's the treatment? Racemic epi. Is it on the board? Oh,
No.
Did you say it earlier? I didn't hear you. Sorry.
Yeah.
Rob said Franklin.
Yeah, exactly. Just Franklin. So there's no definitive treatment. Basically, the patients get better on their own from the viral infection. You're just giving the steroid as an anti-inflammatory, and if they're in acute respiratory distress, it's basically, you can give epi. Nebulized epi is, racemic epi is half of, it's the L isomer of, or an isomer of epi. So epi works too. Chickenpox. So varicella zoster virus. So the varicella viruses, end up, zoster is obviously a sequelae reactivation of chickenpox that most of us get when we're kids. These days, they give the vaccine, and so a lot of younger people don't actually get chickenpox. I don't know the duration of the vaccine, if you need to get another one later on in life, if you have just never had chickenpox in your life. But so, we don't really see as much chickenpox as we used to because of that. The key to chickenpox, as far as the rash, is, anybody know? That's true, treatment-wise, but recognizing that it's chickenpox as opposed to another virus. They all give you kind of a vesicular rash, and so there's like a little bit of a fluidy top. But there's one thing that differentiates chickenpox usually from other things when you're looking at the rash itself. It's kind of present here when you're looking at it. It's of different stages. So usually it erupts in the same area multiple times, and so as a result you see lesions of different age. So you'll have some dried crescent lesions, you'll have some active lesions. If it's just day 1 or 2, everything looks active, but after that, and so usually there's like some lesions of different age, I guess is the best way to say it. Whereas with the other viral infections and viral exanthems, they tend to all be of the same age when you're looking at it, as far as like what the rash, the lesions look like. So this is shingles, zoster, and this is the great. So I tell everybody, like PA students, MD students, etc. You always like someone told me this, and I remember being like, yeah, of course. And then invariably, at some point in your healthcare career, you end up seeing somebody with chest pain, and you do an entire workup on them, and then you come back, and at the very end, after they've had blood work, an EKG, a CT angiogram to make sure there's no PE or dissection, and they're like, does this rash have anything to do with it? And you're like, fuck, if I had just looked at their skin at the beginning, we would have been done 4 hours ago. You feel kind of bad. But that's why you should just look at the skin of everybody that you're seeing in that area. where they're having pain. So, chickenpox is highly infectious, airborne. You use contact isolation. You want to get them out of your environment wherever they are as quickly as possible. So you see somebody with chickenpox, you want them out of the ER as fast as they can before they give it to other people that potentially could be exposed. I remember when I had chickenpox, I just got kicked out of my pediatrician. She saw one look and she was like, "Ow, I'll call you." And called my mom. So it was a very rushed visit. But yeah, I mean, it makes sense because it's highly infectious. Susceptibility and resistance, there's a 10 to 21 day incubation period. Most people are immune because the virus never goes away. You get chickenpox, you get better, and the virus actually tends to hang out. I think it's called the dorsal root ganglion in the brain, and it hangs out there and it does nothing. It just sits there. Your immune system basically keeps it in check till you die. But what happens every once in a while is your immune system fails, or your immune system is weakened because of concomitant illness, too much stress, something like that, and you have too many stress hormones and you're functionally immunosuppressed, and then the virus breaks out and then travels down and it erupts in whatever dermatome distribution, and that's how you get varicella. It's a re-exacerbation of that chickenpox virus that was hanging out in one of your nerve cells, and then comes out in along the dermatome, which is why it's a dermatomal rash by definition. So pregnant women are at increased risk of getting severe disease from chickenpox, which is why there's always that precaution about pregnant women. I think it's a torch virus too, which is torch stands for, what is it, toxoplasmosis. I forget what the O is. Rubella. These are the things that can mess up your baby. So the rash, it's little vesicular rash on a red base, and they usually just look like they're in multiple stages when you're seeing it. So if you've never had chickenpox and you've never had the vaccine, then you have to be careful. Everybody else should be immune. Mumps. So mumps is a real deal. It's a real thing. It happens. We had an outbreak of mumps at Marist a couple years ago. I don't think this past year or the year before we had it, but it does pop up every once in a while. It's a paramyxovirus. Classically, it will affect the salivary glands, which is why they get parotitis, the big swollen glands. It tends to extend down and around this whole area. Occasionally, it can cause severe disease, but for the most part, most patients just develop this facial swelling, mild febrile symptoms, and then get better. It's a pretty severe case of mumps. Occasionally, patients can get, and like men can get orchitis, which is terrible.
Yeah.
Anything that happens to men's urinary systems is terrible. But orchitis, and as a result, you become sterile, so to speak. So in that sense, there's potential for severe disease. And once in a blue moon, you can get encephalitis, but that's very uncommon. Once again, droplet spread, which is why we wear masks to prevent things like this. And this is on the MMR, so anybody that's been vaccinated with an MMR is generally immune. What happens is the immunity wanes, and so it tends to be around college age, and that's why mumps pops up in college age people, and you get outbreaks in college and university settings, etc. Rubella, it's another of these sort of classic diseases of childhood. The maternal transmission is the concern because rubella is a torch virus, and the torch viruses are the viruses that pregnant women, when they acquire, can cause severe congenital defects. And so rubella in a pregnant woman is a real bad situation, or potential bad situation. The kids can get congenital heart disease, eye inflammation, they can be MR, deaf. 90% of neonates born to mothers infected in the first trimester develop congenital rubella syndrome, which is, a severe bad outcome. Most of the time, rubella as an infection in people not in utero do okay. It's like a viral syndrome that gives you fever, or a characteristic rash. Rubella is German measles, right? I always get that confused. So fever, flu-like symptoms, and then you get this red maculopapular rash, forehead, face to extremities, lasts a few days and then goes away. Encephalitis, quite rare, doesn't really occur. Younger females develop a self-limiting arthritis. So it's the congenital rubella syndrome that you're really worried about. Once again, this is an illness that people just get and then get better eventually. It doesn't take too long. It's the first trimester pregnant women that are at high risk of causing, developing severe problems with their offspring. So measles, a little more severe. Although most cases of measles are, just like any viral infection, people get the signs and symptoms and then get better. But a small percentage of those patients can get panencephalitis, kids, babies, and end up having severe, terrible outcomes, which is why we do all this vaccination. So, what's the classic measles presentation? Anyone? Starts with a fever. Everything's fever, right? It's infection. So they start with a fever, and then I think on like a day or two after that, you can get these Koplik spots, which are these weird pharyngeal spots, but they're not always present. And then like day 2 to 3, you start to get the rash, which goes from the head down, and it travels down to the torso. So here's a measles rash spreading down to the torso, front and back. So the prodrome of the conjunctivitis, I forgot about that. Conjunctivitis, sort of a little photophobia, high fever, cough, and then a day or two before the rash, you can get these Koplik spots with these little blue-white centers, lesions in the mouth. And then the rash is maculopapular and just spreads from face, neck, torso, lasts for about a week, and then sort of goes away as in the same order that as it came. The severe complications, the most dangerous is the panencephalitis, subacute sclerosing panencephalitis, with resultant brain damage and or death, pneumonia, eye damage, myocarditis, all the things that can happen from it. And so it has the potential to cause severe disease. I think, we've got this epidemic going on in Texas. There's the last I read, it was like 400 or 500 people infected, and I think 2 people died. So that's a pretty significant amount. Once again, BSI, student safety, wear a mask. Ebola. Fortunately, we don't have too many Ebola scares. We had a big one a few years ago. I guess that's more than like 5 years now. It was pre-COVID, right? Contact and droplet. Ebola is spread through non-intact skin or through mucous membranes. It's usually when it's transmitted human to human, it's from blood or body fluids that the person gets in contact with an infected person or a body as a result. The problem with Ebola is the mortality rate is quite high, like 30%. And so, when outbreaks occur, it's like the deadliest of infections, right? So fever, intense weakness, myalgias, body aches, headaches, sore throat, which is tough because all illnesses cause this, right? Almost everything we've talked about. But untreated and with progression, patients get diarrhea, vomiting, they go on to develop renal and hepatic insufficiency, and they get DIC, disseminated intravascular coagulation, when you're bleeding and clotting at the same time in the body, and ultimately, succumb. So, once again, standard droplet contact precautions. I mean, Ebola is if you guys lived through were you guys working in EMS during the last thing where, the gowning head to toe, and, if you gown wrong, then potentially you could, kill the world. Big deal. We had this horrible, I was at NIAC during that time, and it was a long time ago. Talking about at least I've been up here 10 years, so sometime, at least it was between 10 and 15 years ago, they were having people go to hospitals pretending to be having recently traveled from West Africa in high-risk countries, so that they could assess the ability and preparedness of the ERs. And so we had some guy with a very convincing story. Was recently was a public aid worker and was with UNICEF or whatever, and just got back from West Africa with fever, and everybody's flipping because we're like, it's happening, and sure enough, we did everything right, but I think we inadvertently exposed like a certain percentage of the waiting room, and so it wasn't like that great. And we were on the phone with the CDC, and then finally they told us after we were literally calling the CDC. Yeah, it was an interesting event. And we had a couple false positives, patients that kind of fit the definition. We had to do everything just like that, and then ultimately they ruled out. So fortunately for us, Ebola is pretty rare, and when they do get outbreaks, we get well enough in notice in advance that everybody's kind of primed and ready when there's been a potential outbreak, and then potential travelers coming from that area. Norovirus. So norovirus, super common. We get outbreaks and epidemics of that in Dutchess County. I feel like every year, it seems to happen. Spore-forming organism is responsible for 90% of non-bacterial gastroenteritis worldwide. True. Profuse vomiting, abdominal pain after exposure. Happens very commonly on cruise ships. That's the big fear on the cruise ship, because then everybody gets it because it's pretty infectious. Nausea, forceful vomiting, watery diarrhea, weakness, low-grade temperatures, and it's really a matter of really trying to keep all their body fluids and mask prevention so that you don't get sick yourself. Pertussis. So pertussis is the agent that causes whooping cough. It's part of the Tdap, tetanus, diphtheria, and pertussis. Affects the oropharynx and the upper respiratory area. Once again, direct contact, airborne droplets. It's very contagious. The classic presentations, is the same as all of these essentially initially. Viral syndrome, fever, cough, a runny nose, etc. The difference is most viral illnesses last a week, and then the cough can linger for 3 weeks, but it doesn't get worse and become paroxysmal, where these kids, untreated, get this progressively worsening paroxysms of cough, where they're coughing so hard that they don't have time to breathe in when they're coughing really hard, and as a result, they get that whooping sound. And so it's the whoop that it's named after. It's treatable. It's blank. It's treatable.
Go.
If you click it again, there's
There you
a
go.
video.
I had inserted a video, that's why.
Oh, really?
Let's see if I
How do I play it?
I got it right here.
Got it.
No, not unless you're playing this Dutchess Community College.
This is the ad before, right?
Great target ads.
It's a whoop. Go to the whoop.
I'm working on it.
Just click to the coughing.
Yeah, okay. That would. Tell me how to the computer, but not the speakers. That's a different button.
Listen quietly for the whoop.
Can you hear it?
That kid looks like a lot like my son did. My son did not have whooping cough, but he just looks like my kid.
There you go. Okay, that was the booking. Then they went to the
Got it? All right.
You guys can play it, like it's on the, it'll be on the thing if you wanna play it at home, you can hear it better.
Yeah, or just Google whooping cough and audio, and you'll get a lot of that. All right. So we treat, if you catch it early, then you treat it with, I mean, these days we use azithromycin. It's just got a better side effect profile than erythro, but that can reduce the symptoms and decrease the duration of illness. But if you get it past a certain point, I don't know what that point is, so we always treat it if we diagnose it. The treatment, if it's already fully evolved, doesn't really decrease the duration of illness much. So early is better than late. In general, patients are vaccinated with the Tdap, and that prevents it. Older people can get it later on in life as the immunity wanes. So influenza. So influenza is a real deal. You know, everybody's seen influenza. Not everybody's had influenza. It's a terrible, like, miserable illness. Of like, and for anybody that's seen people with the flu, they tend to be like, people are always like, oh, I had the flu, but they didn't really have the flu. And then people that have like a severe strain of influenza A, they look miserable. There's different types of influenza. A and B are the ones that we classically see every year. And the way they determine the strains, there's, you know, like, it's the type and then the subtype and the code. So, for instance, the terrible one, or the one that, anybody know the highest, the most invasive and causes the most severe disease most commonly? You heard of H1N1? So influenza A, H1N1 is the... It causes just severe disease everywhere. It doesn't have to be meningitis, although you can get a meningitic picture. But most of the time, like when people get fulminant influenza.
It's swine flu.
Oh, swine flu, yeah. I misheard you. I thought you
was
said,
like, what
I
is
thought
he
you said
talking about?
spinal fluid. And I was like, yeah, but swine flu, exactly. That's H1N1. And, you know, they get outbreaks of H1N1 every couple of years. But that being said, most patients with swine flu just have flu. It's a miserable illness, but a small percentage of them get severe illness and can get fulminant disease. It can kill people. You know, when it's in its worst state, it can be one of those that causes fulminant rapid death. If anybody wants to stay later, I'll give you a great story about fulminant influenza. I spent 4 months in court defending myself. We won. We didn't do anything
Was
wrong,
that the
but
case from last year when you were in court?
it was a couple years ago.
Or-
Yeah, 4 months. It was terrible. 3.5 months. But that being said, influenza for most people is just a miserable 5-day illness. A small percentage of patients progress to complicated influenza, which can range from the most common complication of influenza is pneumonia, but it can cause encephalitis. It can cause pretty much any organ failure, depending. But the majority of the people are sick and for a week to 2 weeks and get better. Airborne spread, hand to nose, mouth to eye contact. The virus can persist, and so that's why it's easily transmitted and why we get epidemics of it. So with influenza, most people are contagious for like a day or two before they get the illness until several days after they're symptomatic. Classic fever, shaking chills, headache, myalgias, body aches. There's a dry cough, hoarseness. Occasionally you get like nasal respiratory symptoms. We see 2 waves every year. The way they look at the vaccine is the influenza travels around the world, basically. And so they look at what's coming towards the U.S., the most common strains, and every year they pick the 3 most prevalent strains that they think are going to come to us, and they put those in the vaccine. That's why the vaccine changes every year. And so every once in a while they get it wrong, and as a result, like, they immunize everybody against the 3 strains, and it's a different strain that ends up causing the severe disease, and that's when, like, a lot of people get sick. That otherwise, I got the flu shot, but I'm still sick. See, it's not worth it. It's just because every once in a while they get it wrong. But most of the time they get it right, and somebody who has been vaccinated against influenza, you might still get sick, but you get much lower degree of sickness than the people that are not vaccinated. So it's certainly worth it. People that, are like, oh, I get sick from the shot. Yeah, you get sick for a day. It sucks. But having influenza is much worse. And not to mention the chance of getting severe disease, complicated illness from influenza when you're vaccinated is way, 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 way lower. And that's the real benefit of getting the vaccine. So COVID. If you don't know everything about COVID and been alive in the last 5 years, it's surprising. So droplets, direct contact, respiratory secretion. It's very similar for most, in most cases, as sort of a viral respiratory picture. And the incidence, the severity of the disease depends on the strain, but these days it causes a flu-like illness, mostly milder than the flu. I know this last year it was like flu and RSV were causing more severe disease than COVID for the most part. That's because everybody got COVID eventually. And so it's sort of recently in our systems. SARS, fortunately, we haven't had a major outbreak of SARS in this area. Occasionally they get outbreaks in Asia. It's all sort of the sort of avian fear, SARS, I think, was avian initially, and it pops up in the Middle East and in Asia when there are outbreaks of it. Once again, gives you sort of the same flu-like illness picture, but an increased potential for severe disease. Bird flu. We're talking about all kind of similar things here clinically, as far as like how you would clinically dissect this from other things would be very difficult. But anybody that has had exposure to wild animals and presents with these symptoms, it's a big risk, so in theory our Department of Health would be very interested in catching these patients before they spread it. Mono. Another super common illness. We just had an outbreak of mono, like in this community very recently. I want to say, like less than a month ago was the last time I saw a case. And we see tons of cases. Classically, the kissing virus. It's person spread through saliva. They say kissing, but realistically, people that are in close contact with other people, drinking from the same fountains, exchange using glasses, etc. You don't have to be kissing people to get it from other people. So mono presents with sort of a pharyngitis-like picture, fever, sore throat, general malaise, but they usually have a little more profound lymphadenopathy. It gets confused with strep very commonly. Like, look at the throat. What I found is that most mono patients have like severe, like when you look at the worst strep case, those are usually mono. Like, you're like, oh my God, that's awful. And sometimes you test patients because you're working them up and they have both. And so they get, one and then the other. So for mono, the lymphadenopathy is very prominent. They can get a rash, they can get, commonly have headache. It's a long duration illness. Like, you're sick for a few weeks usually. It can take months to recover, but it's mostly in college students and sort of school age people, and as a result, they tend to be pretty healthy folk, and they recover usually without an incident. One of the things that can happen not uncommonly is you get a little bit of swelling of the liver and spleen, which is why they're at increased risk if they're playing contact sports and they recently have mono or have mono. Then they're at risk of like splenic injury because their spleen is stretched, and so they have a no contact sports rule for them until they're recovered. Most Epstein-Barr symptoms get better on their own, whether you treat it or not. Occasionally, we find that these patients, when they have severe oropharyngeal disease, like their throats are so swollen and they're so uncomfortable, a dose of Decadron makes a huge difference. So, if you're going to steal any medicine from your drug box, take the Decadron. Very useful. Once again, BSI, hand washing, etc. Is like this low-grade illness that just seems to never go away, and people are sick for a while. I say we just took a break. Push on. It's 9:25. I think we'll finish early. So we'll look at sexually transmitted diseases. My son, I have a 12-year-old, and I've been telling him since he turned 10 that when he turns 13, I'm going to sit him down and we're going to watch a PowerPoint of sexually transmitted diseases, which he's been eagerly awaiting. He went to health this past week, and he was like, "Dad, you don't have to do it. We had a talk." So I looked at what their talk was, and I was like, "No, son. When I'm done with you, you'll never have sex." So I'll probably use some of these slides. I don't know. HSV. So herpes. There's two subtypes, right? Herpes 1, herpes 2. These days there's a lot of sort of mixing in between the two. The classic teaching though is herpes 1 is the cold sores that almost 100% of people have had HSV1 exposure at some point in their life. And anybody that's had a cold sore has had it. Most kids get it at some point or another. And once one kid gets it, the other kids in daycare, they all spread it because they're, it's just a big salivary exchange at that age. And so HSV1, technically it's an STD, but it's really just a disease that's present in lots of people. HSV2, so this is HSV1, you get a cold sore, it hurts, eventually you get a couple, you take some Valtrex and it goes away, or you take nothing and it goes away. If there's a very extensive amount, then oftentimes we'll give people a course of an antiviral or a topical antiviral. What is it, Brevia? I forget the name of the topical one. Yeah. The problem with
I got one on my fucking throat.
Of course you do.
Right now.
The problem with HSV though is it's one of those things where if you don't treat it right away, then it's kind of like zoster. If you catch zoster past 48 hours, the treatment doesn't usually work much. And so most of the time, by the time people actually get in to get care, they're kind of out of the window. So you have to treat it early, preferably. So this is herpetic whitlow, so this is when somebody gets an infection on their finger. The classic lesions. Usually there's big erythema all around, but you see these little circles that kind of clue you in that it's more of an HSV infection as opposed to a cellulitis or some other type of bacterial infection on the finger. So lesions of herpes tend to be actively, filled with virus, and so exposure to somebody who's actively got sores puts you at an increased risk. So HSV2, I think the statistics are 1 in 6 people. I'm looking around. I can see, no, I can see which of you I would think. No, so 1 in 6 people in the United States has HSV2, which tends to involve your genitalia more commonly. And it can be anywhere on the genitalia. The initial outbreak of HSV2 tends to be a more severe presentation. So patients will have numerous sores and fever to the point, they have systemic symptoms as well. And then after the initial outbreak, subsequent recurrences of HSV2 tend to be less, like profound, so to speak. They're not everywhere. But there's a lot of variability with this disease. And so some people have their initial outbreak, which you'd expect to be severe, and it's just a couple lesions. Of course, you never know, did they have an outbreak at some point in the past that they aren't mentioning or talking about. The lesions can be, sometimes they're asymptomatic, but most of the time they hurt, just like any other sore. What's the sore that classically doesn't hurt? It's a chancre on the genitalia. That's painless chancre is the term. I don't know, do you pronounce it chancre or canker? I think it's chancre. but why do we say canker square? You know what I mean?
Yeah.
But painless chancre, syphilis. The classic primary syphilis lesion is a large chancre that is painless, but painful herpes. So most of the time patients are symptomatic, but they don't have to be. It can be contracted transvaginally, so that's always a risk. And then those patients, neonates are immunosuppressed, so they're at high risk of getting severe disease from it, which is why they'll treat pregnant women in third trimester aggressively. So genital herpes, you get some pictures. You can get HSV2 anywhere, which is why I said there's kind of a mix, because people can present with HSV2 lesions in their mouth, depending on where they contracted HSV2 from. Tends to be miserable illness. Once again, BSI. Don't look, just transport. If you catch the patient early in the course, you treat with, in general, we just treat if patients present with symptoms. You can use acyclovir, valacyclovir, sort of the classic treatments. Syphilis. So syphilis is another great imitator disease that sometimes presents, looks like one thing and ends up being something else later on. So Treponema pallidum is the spirochete that causes syphilis. There's been an increased presence of syphilis in the U.S. in the last couple of years. It seems like it was one of those diseases that was well controlled and then had a resurgence. Kind of come in with HIV therapy, so it's kind of tricky. Like, people were deadly afraid of getting HIV and AIDS, and so they use protection. And then now that HIV is treatable, it's a lifelong disease, it's not something you want to get, but if you get it, you can treat it and prevent, getting AIDS. And so as a result, I feel like the recurrence of syphilis is a reflection that people are less afraid and using, they're less protected as a result. Direct contact with exudates from lesions on the skin or mucous membranes of patients that have it. So syphilis presents with different signs and symptoms depending on the stage of disease. So the initial stage actually doesn't have any of this. It's just a painless chancre, which sometimes goes unnoticed because it's painless. And so if it's like in an area that's, somebody's not commonly inspecting, they might not notice. And so that's the initial manifestations of disease. And then untreated, it goes on, that's primary syphilis. It goes on to what we call secondary syphilis. And secondary syphilis can have dermal manifestations. It's one of the few infections that can go on the palms and soles. And so that's one differentiator. Not a lot of things. Hand, foot, and mouth disease, syphilis. There probably are a couple others, but I can't think of them. But secondary syphilis gives you dermal manifestations. So 4 stages. Here we go. So red, small, what's the name? Condyloma latum. As opposed to condyloma, the one from HPV. Condyloma, I forget the name. I think they're just condyloma when you have genital warts, basically. But these are painless. They're like wart-like lesions in moist warm sites on the body. And these are all signs of secondary syphilis, that rash on the palms and soles. These things last about 6 weeks and then will go away. And untreated, they can get tertiary syphilis. Bald spots, loss of eyebrows. I don't really know that. Ultimately, usually CNS infection is tertiary symptoms. So 3rd stage, latent syphilis, and then at some point patients get tertiary syphilis, which is when they can get carditis, they can get CNS disease, they can get, it's part of the dementia workup. So patients that have early onset dementia oftentimes will get tested just to make sure that that's not the cause. And so you can see how it's an imitator, right? So patients presenting with dementia end up having syphilis. Patients with skin diseases end up having syphilis. And so it gets mistaken not uncommonly. So cardiovascular syphilis, these are talking, over 10 years after, patients can get ascending aneurysms. And so it can present maybe a meningitis-like picture. And so all of these things are sort of different presentations of the same disease, and then paresis of the insane, so progressive mental deterioration, and that's your dementia masking, syphilis masking as dementia. Neurosyphilis.
This is curable though, right?
Totally, yeah. If you a shot of penicillin makes it go away, and it's actually very susceptible to penicillin. So it's like, I think, so if you treat strep throat, you use 1.2 million units of penicillin, which is just it's a shot of penicillin. It's a shot, so it's not comfortable, but you use 2.4 million units for syphilis, one shot, and then do a test of cure later. And every once in a while, somebody needs a second treatment. If they have neurosyphilis or sort of secondary or tertiary syphilis, it's a longer duration of treatment, but that's just a few shots. And so you have this disease that untreated can go on to kill you over many, many, many years, and you can spread. But if it's identified early, it's easily treatable. In fact, they don't like to say it, but there are a lot of oral antibiotics that potentially in combination could work. There's a concern over treating syphilis with oral antibiotics because basically all of these diseases develop resistance over time, and so if everybody's just randomly taking oral antibiotics, eventually they won't work. And it's not to say that they work well. There's limited data, but there's reason to believe that a course of 1 or 2 oral antibiotics in combination would probably work, because you get people with that are penallergic, and they have treat them with an alternative regimen. I forget what they use, but the long and short is you can treat it with oral antibiotics. What they have shown, like doxycycline, you guys know about PEP, post-exposure prophylaxis for gonorrhea and chlamydia. The last couple of years it's come out that treating post-exposure, so after sex, somebody that is potentially at risk with gonorrhea or chlamydia with doxycycline, 200 milligrams, the same dose that you give for Lyme as exposure, has been shown to significantly reduce the chance of transmission of gonorrhea and chlamydia. But what they found is that there was a significant reduction in syphilis transmission as well, which I know a course of doxycycline is not approved as a treatment for syphilis, to my knowledge. Don't quote me on that, and certainly don't take a test based on what I'm telling you. It's not. These are things that I have to look up before I treat, because you don't treat it that often. But, for the most part, the fact that doxycycline is decreasing transmission risk tells you that it's probably susceptible to certain regimens of oral antibiotics, but they don't like to make that public because the problem with gonorrhea is gonorrhea used to be susceptible to lots of oral antibiotics, and now it's resistant to almost all of them. And really, ceftriaxone is sort of the last resort that we have, which it's very susceptible to still. But there is gonorrhea-resistant, ceftriaxone-resistant gonorrhea out there now, and it's because of sort of misuse and frequent use that these bacteria learn to become resistant or evolve to become resistant to the antibiotics that we use. There is another antibiotic that's just coming on the market that is treatment for gonorrhea. That's everybody's happy because now there's a second agent, which is also, I think, IM. So anyway, yes, it's treatable. Long answer. Sorry. Syphilis. Once again, BSI in every shape of the word.
Bless you.
Bless you. So easily killed, soap and water. As far as surface exposure, if it's treated, washed away immediately. And effective penicillin, erythromycin, doxycycline. But like I said, the published guidelines don't recommend using anything other than IM penicillin, unless there's an allergy. Gonorrhea. So Neisseria gonorrhea basically affects the genital organs in men, causes a urethritis, which oftentimes involves some degree of pus, which is why it's like the drip. This other name, gross. Infects mucous membranes. The problem is gonorrhea in women, while commonly just causes like a PID-like picture, pelvic inflammatory disease, prolonged